Hey guys, Dr. Drew Otten here. It is my little stand is having all sorts of trouble. Okay. It is June 12th. It's a little late. I have a flight in the morning I got to catch, but I was trying to get some videos out for you. We're eventually going to talk about this topic, but there's a lot of prerequisite anatomy knowledge that I feel like is just so essential to really being able to make sense of it all. So, what I wanted to do on one of my first videos was to just go over global anatomy, a little bit of global anatomy of the whole spine, but then really heavy and deep on cervical spine. So I figured we'd get into that. And this is kind of one of my first big videos. So I'm excited to get to meet all of you. If any of you are watching my videos, I'm sure stuff's going to pick up here quickly. I'm not sure how fast it'll happen, but I suspect it will. So if you have questions, if you have comments, I love interacting with people on this topic matter. Honestly, everything that I've learned has been either through myself, my own experience, patients that I've dealt with myself, and just people that I've talked to. So I appreciate so much if people have different perspectives, if they think about the anatomy in a different way, if they've heard of a treatment that I haven't heard of. I love discussion. So I'm an open book, open source. If you got comments, anything, I love it. Please make your comments. But let's get into cervical anatomy. Let's just go over this basic overview. So from a broad perspective, spinal anatomy, and we have our skull base, and we have cervical anatomy, or the cervical vertebrae. About to just put this down. Goodness. So we have cervical vertebrae. We have 7 of those, and these are going to be the purple ones. We have the thoracic vertebrae. Yeah, we'll just put that down. And then we have the lumbar vertebrae. We have 5 of those. They're going to be the green. Then we have the sacrum in orange. And so from a broad perspective, another overarching concept we've got to talk about is curvature. It's so important when we get into later concepts of cervical instability, because curvature affects function in so many different ways that people don't understand. So it's just so important. We got to focus in on it. So normal curvature in the cervical spine is a lordotic curve. So normally you're going to have a lordotic curve, which is essentially how I'm forming my hand this way. But what that means is that you're going to have a slightly posterior angulation of the top half of that cervical spine, and then a slightly posterior angulation of the bottom half of the cervical spine. And then the middle portion is going to be further anterior. And then it's going to be the exact opposite in the thoracic spine. So you're going to wrap around and create more of a kyphotic curvature for those 12 vertebrae. So you'd be more anterior in the first portion, and then posterior in the middle portion, and then anterior in the inferior portion. And then we have our lumbar curvature, which is going to get back to the same way that the cervical curve is, which is a lordotic curve. And then our sacrum is obviously going to kind of curve in a kyphotic manner as well. But anyways, so back to the 7 cervical vertebrae. We have our skull base. Sometimes the skull base, you'll hear people referring to it as C0, because we have our 7 cervical vertebrae. So we have C1 through C7, and then obviously we'll just name the skull base sometimes C0 because it sits on top of C1. It just makes sense. So main key players of the cervical spine. Before we get into joints, let's just talk important vessels. Really, there's one really important vessel, which is the vertebral artery. This is very, very important to understand. It's going to run and enter the 6th cervical vertebrae transverse foramen. So there are foramen that run, and we have one of our top, this is our C1 vertebrae here, our atlas. And so you can see there's foramen here that run through. These are called the transverse foramen. And the vertebral artery runs through those foramen at C1 down to C6. You can see the last vertebrae is C7 here, and then we have C6. The vertebral artery is going to come from an inferior source and then come up. It's going to enter that C6 transverse foramen. It's going to wrap up all the way from C6, C5, C4, C3, C2, C1, and then it's going to go into C1. And then when it goes into C1, it's going to wrap up through the transverse foramen, wrap around the base. This skull base is kind of hard to see, but we have kind of a model here. But so it's going to come up through those transverse foramen here and here, and then it wraps around this condyle, and then it's going to join in the back portion of the skull base here, and it forms what's called the basilar artery. And then that goes up to serve the posterior portion of the brain. It's a really important artery because anytime you're moving, especially with cervical instability, vertebral artery can always be implied, because if there's motion of those vertebrae more than what is normal, more than what is tolerable for the body, vessels can be affected. And so that's one of the biggest vessels to be aware of. And since we're talking about vessels, we have our skull base here. This skull base is not really anatomically accurate at all, but you know, roughly, I don't even know if that's accurate, but around this area we're going to have a jugular foramen. Again, don't pay attention to the hole that's there because it's not anatomically accurate, but we have a jugular foramen. I'm pretty sure it's going to come out a little bit slightly anterior and lateral to this these occipital condyles. And the jugular foramen is going to hold a lot of really vital structures. So your jugular vein, your glossopharyngeal nerve, your vagus nerve, accessory nerve. There's a lot going on there. It's a really important foramen and just important to understand. So we got that covered, and that's another vessel that runs in that area. Obviously down here we have the carotid canal too, so that's something just to keep in the back of your head, because the carotid artery is going to run with a lot of those structures as well within something called the carotid sheath, which is going to run anterior to the cervical spine. So it'll be coming off that skull base there. Okay. All right. We have no intervertebral disc at C0, C1, no intervertebral disc at C1, C2. Our first intervertebral disc, no intervertebral disc at C0, C1, no intervertebral disc at C1, C2. Our first intervertebral disc is at C2, C3. So, and then obviously we have intervertebral disc running down the whole spine. So, we got that covered. All right. I have a model here for the top 2 vertebrae and the skull base. So we'll kind of use that to go over some basics here. But we have our top 2 vertebrae. We have our skull base, and they're going to sit like this. We'll take them off, taking off C0, taking off C1, taking off C2. C2 is very unique. It has a projection called the dens, or the odontoid process. It's really important because this main motion is what really helps us to perform rotational movement. In this odontoid process, articulating or moving within the facet for the dens. So facet for the dens is just basically kind of like a placeholder. It allows it to rotate with smooth motion. And so this complex right here is what allows us to make this movement. The C0, C1 is going to allow us to make that nodding motion. So anyways, you can see how really unique these two vertebrae are. I'm just going to let you get a really good look here, and obviously you can look more online at how all these look. But none of the rest of the cervical vertebrae and any of the vertebrae really look like these two vertebrae. They're very, very unique. And so just talking anatomy for a little bit, we have the anterior arch, posterior arch, transverse foramen. We have, like we talked about, transverse foramen. And then we have the transverse processes, like we talked about, which really are more pronounced, more down into the thoracic spine. You see the transverse process, and people might call them the TPs. But those are really important, and they're important over here because obviously we talked about the vertebral artery. But anyways, you can really get a good view on the vertebral canal with this model. So these are the top two vertebrae, and if you turn it in axial format, you can see right down that barrel of the gun. And you have your vertebral canal that runs right here, which is going to have your central nervous system, your spinal cord. Obviously, within the spinal cord, you have, we could take a whole course on that, but you have the spinal cord, and then outside of the spinal cord, you have different coverings. You have the dura mater, the arachnoid mater, the pia mater. All these structures are going to cover the central nervous system. And then outside of the dura, we have something called the epidural space, which is really important when it comes to understanding cervical pathologies and just cervical anatomy in general. Because when you have certain pathologies coming into play, sometimes that epidural space is affected. Also, it's really relevant for different treatments. Sometimes epidurals are performed from different angles, whether it's a transforaminal epidural or an interlaminar epidural. These are really important anatomical landmarks to understand. Since we're kind of talking about the epidural space, then one other major covering that you should understand is the ligamentum flavum. So, and I don't think we're going to be able to really get a good look at what that is from this model. I guess we can. You can kind of see our spinal cord here, but on the posterior, see if I can get a good angle here for you guys. Let's see. On the posterior aspect of these neural arches, and if I could get you this view on this one, I would. There's going to be something called the ligamentum flavum, which is a connective tissue which is going to run posterior. And if somebody ever does an epidural, you actually have to pierce through the ligamentum flavum to get into that vertebral canal. It's a really important structure to understand what it is, where it's located, why it's there. So now that we talked about that, let's talk about the anterior and posterior longitudinal ligaments. So there's actually ligaments that run anterior to the vertebrae. The one that runs anterior, which provides a lot of stabilization. So this anterior longitudinal ligament is going to keep structures from translating. So if you have one vertebrae here, and it doesn't apply to just these two vertebrae, it actually probably applies more here, but it runs on this whole anterior surface. It's going to help stabilize the spine in this direction, whether it's this inferior vertebrae moving anterior on this vertebrae or this superior vertebrae moving anterior on the vertebrae below. So it's going to stabilize there. And in the same way, we have the anterior longitudinal ligament, or the ALL. We also have something called the posterior longitudinal ligament, or the PLL. And that is going to run directly posterior, so not as posterior as what we talked about with the ligamentum flavum, but it's going to run directly. Again, we can't really get a good view with this model, I apologize, but it's going to run directly posterior to this surface of the vertebrae. and it's going to run down that whole spinal canal. It's going to provide stability as well. So we covered that. So obviously the spinal cord is encased within cerebrospinal fluid. That's something that's really important to understand, because as we start to talk about pathologies, cerebrospinal fluid flow and just the overall support that the cerebrospinal fluid provides for the vertebral column, for not the vertebral column, but the spinal cord itself, it can be inhibited, it can be affected. It's really relevant in certain aspects of cervical instability, but even more so in something like spinal stenosis, and a few other pathologies as well. So that's something that's important to keep our eyes on. So more anatomy here. We have the 7 cervical vertebrae. We have the spinal cord running down all the way from, the base of the skull down to, it goes down to about L2, but we don't have to talk about that right now. So it's going to run down, and then we have nerve roots. So you can see these little projections here are going to pop off at each level, and they service different aspects of our upper limbs. Once we get down to this region, they service our abdominal cavity and whatnot. So, but these are really important, and they run through something called the intervertebral foramen. And they're just really important to understand. Actually, there are some other aspects of anatomy which aren't as important right now with this conversation, but we do have something called the medial branches, which come off of a dorsal ramus of one of the nerve roots. And that's kind of a whole anatomical conversation of itself, but these are really relevant because they service facet joints, and they innervate and provide sensory information. And so they do pop up sometimes, and they do get treated. The medial branches, which come from 2 different levels, and they innervate these facet joints that we were talking about here. And they can cause pain, and so sometimes either medial branch blocks or a sequential step to that might be a radiofrequency ablation. Sometimes that occurs. And it's just important to be aware of, because sometimes you might have patients that are coming in that are getting those procedures, and just understanding it from an anatomical perspective is important. So yeah, we have that. One thing we didn't talk about here. So with the facet joints, with each facet joint, we have for one vertebrae here. So let's talk about that for a second. Let's just focus in on, we have C0, C1, C2, or I'm sorry, C0 is up here, and then we have C1, C2, C3, C4. Let's focus in on C4. So on C4, this backside flat surface on each vertebrae is called a lamina. So it's just a flat surface on the backside of the lamina, and then the lamina turns into the spinous process. Obviously, we have our bifid spinous processes here in the cervical spine. Lamina is important to understand because between these spaces, you have lamina here, lamina here, lamina here, lamina here. So in between those spaces is called the interlaminar space. Not as relevant with cervical instability, but there are treatments there where people go into that space with a needle. So it's important to understand. We talked about the intervertebral foramen. There's usually, in most people, as long as the foramen isn't too encroached, there's a little bit of space above the nerve root and below the nerve root. That's important to remember because there's sometimes treatments that take place there. We have our intervertebral discs. Keeping an eye on these because they're so important for stability. So important. And we want to see nice, big, healthy, juicy discs that's, indicating a nice, really healthy cervical spine, and so that's something we like to see. I didn't cover, on each vertebrae we have a superior articular process and an inferior articular process. So on each facet joint it articulates with the one above. So this one will articulate with this one. Yeah.
Whenever you're done, could you please pick out a shirt and pants? Because I haven't packed your suitcase.
Yes, I will, okay? I am almost done with this video, all right?
And maybe pack a jacket.
Okay. Okay, anyways, sorry about that. So let's finish up this video because, like I said, we got a flight in the morning. So, the inferior articular process of one facet joint is going to articulate with the superior articular process of the vertebrae below. So we have superior articular process, inferior articular process. And anytime you're flexing, extending, laterally bending, either direction, or maybe it's a extension or a flexion with a little bit of a lateral bend, you are going to be articulating or moving those facet joints. And so it's just so important. And it's important to understand that we have ligaments. We have capsular ligaments that run on the posterior aspect of those facet joints, and they provide stability to the spine. You actually have a capsular ligament on C0, C1 as well, and it runs all the way down that cervical spine. And yes, so we have that. Couple other, like we said, we're not going to get into too much anatomy and muscles, but they're so important. But there are some muscles, such as the suboccipital muscles, which are really important for craniocervical instability. You have the rectus capitis posterior minor, rectus capitis posterior major, which all of them run mainly on the nuchal ridge down to C2. Rectus capitis posterior minor, rectus capitis posterior, I'm sorry, it's a mouthful. Rectus capitis posterior minor, rectus capitis posterior major, obliquus capitis inferior. All of these muscles are really important to understand, and I will make another video to talk about those more in depth because they're really important when we get to talking about something called the myodura bridge, which is really important, has some corollaries with cervical instability and providing tension forces on the dura itself to help us with torsional movements. And I'll get into that, explain more of it, what it means. But this is just a general roadmap of cervical anatomy. I hope that this got you inspired about cervical anatomy, got you inspired about cervical instability, whatever you want. I hope maybe this added some value to your life. So, all right, have a good weekend, guys.